All right, we're just giving it a few seconds before we begin. People are joining. Okay, hello everyone, and thanks for joining our annual 2025 CPT Code Set webinar. My name is Jordan Leibitz. I'm part of the marketing team here at IMO Health. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded. A copy of the slide deck, a certificate of attendance, and the recording will all be made available to you after the webinar. So be on the lookout in your inbox this week. I just want to give you a heads up. This webinar is jam-packed with a lot of content. So if for whatever reason we run past the hour, just feel free to drop at any time. Like I mentioned, we're sending the recording out anyway. And we will do our best to accommodate all the questions that come in after the webinar. But for any reason yours is not addressed, we will follow up with you after the presentation. Today, we have our lovely coding experts, Jude Bronnert. She is our VP of Global Clinical Services, and Shelly Jude, our Director of Global Clinical Services. So with all of this being said, I'm going to go ahead and pass it over to Jude.
Great. Thank you, Jordan, and welcome, everyone. Before we dive into the content, I wanted to take a moment. For nearly 3 decades, since 1994, IMO Health has been revolutionizing data capture at the point of care. Our comprehensive clinical terminology and code mappings allow clinicians to document in their own words while seamlessly capturing essential clinical details and billing codes. And as we're getting ready to talk about, the maintenance of these codes is also very important throughout this, and we're going to dive into changes for CPT. And here's our agenda of the topics that we will review today as they are seen here on the slide. But first, let's take a quick look at the numbers for 2025. There's a total of 420 changes overall, with 270 added codes, 112 deleted, and 38 revised. In addition to code changes, there were multiple guideline changes, revisions, and additions. We won't be able to go over all the updates at this time, but we have selected the most relevant areas to share with all of you. We're going to begin with neurosurgery. Neurostimulator code changes is the biggest area we will review. Vagus in Latin represents wandering, and this long cranial nerve does just that throughout the body. The vagus nerve plays an important role in overall wellness. And while there are many aspects of vagus nerve stimulation to discover, it is thought to help control seizures by improving blood flow to the brain, along with altering electrical patterns during a seizure. It is also thought to increase the level of norepinephrine and serotonin in the brain, which have a role not only in controlling seizures, but also regulating an individual's mood. Vagus nerve stimulation also stimulates the motor cortex areas of the brain that control arm and hand movements, therefore playing a role in ischemic stroke rehabilitation. Now let's look at this year's code changes. Last year's changes were made to skull-mounted cranial neurostimulators. This year, code changes center around integrated cranial neurostimulators. It's important for proper code reporting to know the type of device. Typically, a vagus nerve stimulator has a subcutaneous pocket for a pulse generator and leads that run into the vagus nerve. With an integrated vagus nerve stimulator, the battery and leads are integrated and positioned to encompass the vagus nerve. A new code, Category 3 codes, were created as shown here for open implantation, replacement, removal, and electronic analysis. New parenthetical notes were created to help provide clarity in reporting. IMO Health recommends reviewing all the notes to ensure proper code assignment for vagus nerve stimulators. The last change we'll review in relation to nerves is related to EMGs. To keep up with current clinical practice, the code 96003, along with parenthetical notes, was deleted. And next we turn our attention to cardiovascular. Let's start with aorta angioplasties. The endovascular repair of congenital heart and vascular defects subsection guidelines and parenthetical notes have been revised or created where necessary for coding clarification, as we will review first. A coarctation is typically present at birth and not uncommon to be present with other congenital heart defects. It accounts for approximately 5% of all congenital heart defects and most often diagnosed in children or adults under 40. It forces the heart to work harder to pump blood, and the treatment for coarctation involves opening of the narrowing. An aorta blockage also reduces blood flow, but due to a different underlying pathology. Blood flow is reduced not typically due to the shape of the vessel, but rather a disease process such as atherosclerosis. The treatment is targeted at clearing the blockage. Keep in mind these conditions are not mutually exclusive and may be present in the same or different vessel areas or zones. As an aortoangioplasty can be performed for either reason, the notes were revised for coding clarification, as we will look closer at on the next slide. The coding notes for 33895 and 33897 were revised to indicate the reporting of clearing a blockage and opening a coarctation should be reported when performed in different zones. If the treatment of both conditions occurs in the same vessel zone, then only one code is reported. Continuing with cardiac changes, next we'll look at the atrial fibrillation ablations. Ablation destroys or removes either part of the body or its function. In the instance of ablation for atrial fibrillation, the procedure requires the use of a catheter to deliver either hot or cold energy in specific nodes or areas of the heart. This destroys that area and creates scar tissue, which prevents abnormal electrical signals which were leading to the atrial fibrillation. The guidelines in this section were revised for clarification of current atrial fibrillation ablation methods. 93656 code descriptor was also revised to clarify the placement of the catheter in the atrium is necessary for this procedure. Next, we'll look at new codes for cardiac-related therapeutic drug delivery. We're going to take a closer look at this new subsection created for reporting this percutaneous coronary intervention by the therapeutic drug delivery balloon. This new subsection, along with new guidelines, have been created for reporting the therapeutic drug delivery via the balloon in a coronary artery. This procedure centers on delivering antiproliferative drug treatment directed into the coronary artery. Traditionally, coronary angioplasties have centered around the mechanical dilatation and maybe a stent insertion. Antiproliferative drug agents are designed to disrupt cellular replication and prevent restenosis within the coronary arteries. This procedure differs from the traditional coronary interventions in that it involves a drug transfer process from the balloon to the atrial plaque. It's important to note that both new codes include all the services within their descriptor, which are an angioplasty, mechanical dilatation, catheterization to access the vessel and the lesion, drug delivery to maintain the patency, along with all imaging. There is a long note at the start of this Category 3 subsection regarding these two new codes to help further clarify when procedures are separately reportable. For example, a diagnostic coronary angiography performed at a separate session is separately reportable. Next, let's turn our attention to the cardiac contractility modulation defibrillator, or CCMD. CCMD system combines the therapy for chronic heart failure with defibrillation protection into a single system. This system includes a pulse generator, two transvenous leads, one that is pacemaker and one defibrillator. Placement is like other pacing defibrillation cardiac devices in that the leads are placed transvenously with the pacer lead placed on the high septum, while the defibrillation lead is placed mid-septum. The pulse generator is located in a subcutaneous pocket. The new codes are patterned after other pacing defibrillating cardiac devices with insertion, removal, and repositioning codes, as we will see next. Here's a look at the repositioning and relocating new codes. It's important to note there are also new codes for services such as device programming and evaluation. Here's an example of one of the new programming codes. The pattern of the codes follows similar device codes for evaluations such as remote or in-person. Please see Category 3 subsection for details regarding the other codes as well as notes for what services are included. In addition, multiple parenthetical coding notes have been added throughout the CPT to facilitate proper code reporting. Lastly, we will look at continuous external ECGs. To fill a coding gap, new codes have been created for reporting non-monitored external electrocardiogram services lasting more than 15 days. The codes represent a time frame of more than 15 days, but up to 30 days. As you can see on the screen, the parenthetical coding notes were revised to facilitate proper code reporting. And now it is time for our first polling question. An 85-year-old patient presents for an internal or interventional coronary angiogram due to restenosis of a coronary artery. An intracoronary drug delivery balloon was placed after the vessel was dilated. The antiproliferative drug was administered directly at the site of the restenosis. What is the proper code or codes assignment? 92924 with the description, as you can see, percutaneous transluminal coronary atherectomy with coronary angioplasty when performed, single major coronary artery or the branch. The same code 92924 and 0913T with the description of the percutaneous transcatheter therapeutic drug delivery by intracoronary drug delivery balloon, including the mechanical dilatation by non-drug delivery balloon angioplasty. The code 0913 by itself with the same description, or D 92937 and code 0914T with the code descriptor for 92937 is percutaneous transluminal revascularization of or through the coronary artery bypass graft, and any combination of an intracoronary stent atherectomy or angioplasty, and for code 0914, percutaneous transcatheter therapeutic drug delivery by intracoronary drug delivery balloon performed on a separate target lesion from the target lesion treated with balloon angioplasty. Jordan, would you please launch the poll?
Yes. If you could turn your attention to your screen, pick what is the best answer. June, I think you need some water after that. That was quite the mouthful. All right, just a few more seconds.
I know those descriptions are lengthy.
All right, I'm going to go ahead and close it out. So it looks like a lot of folks said B.
Oh, actually, the correct answer is C. And this is where the those guidelines for what is included is part of those code descriptors. And so that is where that when you look through the coding notes in these new sections, that the code to deliver the therapeutic drug includes those services on accessing those vessels, including that dilatation. So let's continue and looking at vaccinations next. And first, let's start with the release calendar. So the release and effective dates for immunization codes, which include vaccines and immunoglobulins, have been revised to 3 times a year. The prior release was biannual. This change was done with the collaboration of the CPT editorial panel and the Immunization Coding Caucus, or the ICC. The ICC is a special work group that provides input for panel considerations regarding immunization topics. This group was previously known as the Vaccine Coding Caucus, or the VCC, and the name was revised to include the immune globulins as part of their charge of the work group, that they have established specific language conventions to ensure structural consistency and the use of relevant terminology. We will see revisions to this section as this group continues their work, but let's look at some of the changes for 2025. Here you can see on the right-hand side of the screen, deletion of obsolete products for influenza virus vaccines along with title revisions. By revising the title of code 90661, it may now be used to report trivalent influenza virus vaccines derived from cell cultures. 2 new codes were created for mRNA influenza virus vaccinations. Code 90637 is recommended for ages 18 through 64 years old, while code 90638 is recommended for ages 65 years or older. 30 mcg is considered a standard dose, while 60 mcg is considered a high dose. On the next slide, we will review other vaccine changes. And on this slide, there are 3 newer codes with their release and effective dates. For pneumococcal, the PCV21 protects against 21 different serotypes of the Streptococcus pneumoniae bacteria. New code 90624 reports immunization for meningococcal infections, and the new code 90695 is for immunization agents against the avian flu. There are 9 known subtypes of AH5 viruses, also known as avian flu. It is widespread in wild birds throughout worldwide, but there are also outbreaks in poultry and U.S. dairy cows. This new code was established to help address emergent public health issues. The Food and Drug Administration provided emergency use authorization for the H5N8 avian flu virus. Now let's turn our attention to digital medicine. The CPT editorial panel created the Digital Medicine Coding Committee in 2023. They are charged with responding to coding issues or requests involving digital medicine and/or artificial intelligence components. Category 30902T describes the use of an augmentative algorithm to derive the QTC from mobile ECG data. The procedure involves analyzing 30 seconds of ECG data or tracings to gather data for the augmentative algorithm. Code 9032T represents an AI platform that analyzes echocardiogram data to assess heart failure along with preserved ejection fraction. Codes 0903T through 0905T have been created to report generation of a 12-lead ECG from a lesser number of leads ECG. A 12-lead ECG result is generated, but the algorithm input is less than 12 leads, like, for example, 8 leads. The code pattern represents the other ECG reporting patterns, as you can see on the slide. On the next slide, we will look at similar services, but for other body systems. 0877T describes the qualitative analysis of chest CT imaging data. 0878T describes an augmentative analysis when obtained with concurrent CT exam of the same structure. 0898T is a new Category 3 code to report non-invasive prostate cancer estimation mapping. It is an augmentative data analysis to better visualize the location along with the extent of prostate cancer. This map is clinically meaningful to the provider to help determine the location and the size of the margins and thus influencing treatment recommendations. Now let's look at pathology and laboratory changes. Proprietary laboratory analysis updates continue to be a large number of code changes in this area. We recommend review of Appendix O for those specific changes. There is one area I wanted to highlight, and that is CAR-T, as we will see on the next slide. Chimeric antigen receptor T cell, or CAR-T, is a cellular and gene therapy that involves collecting, processing, and genetically modifying those cells or tissues. Once the modification process is complete, the genetically modified cells are administered for treatment of a life-threatening disease or condition. 4 new codes, as you can see here, were created to report this therapy. 38225 represents the harvesting of blood-derived T lymphocytes. The physician or other qualified healthcare professional supervises the blood collection along with patient monitoring. For receipt and preparation, the physician or other qualified health professional oversees controlled thawing to ensure the viability of the genetically modified cells. For the administration, the physician supervises the initial infusion for the first 15 to 30 minutes and then remains available to manage any complications. And the last area that I will review is radiology. Let's start with the new subsection for MR safety procedures. This new subsection created to identify work associated with assessing and providing safety services. As MRs have strong magnetic fields, they require special safety considerations such as identification of metal objects. It doesn't matter whether the object is a foreign body, is a bullet, or medically implanted devices. It's important to identify the device. There are device-specific considerations once identified prior to having the MR procedure, such as will the functionality of the device be impacted, requiring additional services. And new codes were created, as we will see on the next slide, to reflect these safety procedures. The new codes differentiate between services provided in advance of an MR procedure versus services the day of this exam, as you can see here on the slide. The codes 76014 and 76015 are time-based codes. Regardless if the service was performed in advance or the day of, all must provide a written report. The coding notes at the start of this new subsection contain additional detail about proper reporting of these codes. For example, if a cardiac device such as a pacemaker or defibrillator requires interrogation or programming services before or after the MR examination, there is a note to see the appropriate cardiac device evaluation code. Next, we'll look at more imaging changes. There has been a debate if the add-on code 75774 was appropriate to report for venous procedures. The revisions to this area are intended to clarify that this code is appropriate for both arterial and venous procedures. Two codes for percutaneous radiofrequency thyroid ablation have also been created, as you can see on the right-hand side of the screen. Code 60660 is for the ablation in one lobe, regardless of the number of nodules, while code 60661 is an add-on code for an additional lobe ablation. We will finish our review of radiology with a review of new Category 3 codes on the next slide. And here's a list of several new Category 3 codes, and I wanted to highlight a few. Code 0901T has been established to report the placement of a port for bone marrow sampling. The port aids in patients who have conditions such as leukemia or multiple myeloma who need to have frequent bone marrow samples to determine the effectiveness of treatment. Code 0946T has been established to reflect CT-guided orthopedic implant movement analysis. This analysis is used to identify whether there is a loose implant or pseudoarthrosis. This insight shows how and where the implant is moving. And lastly, code 0398T was converted to a Category 1 code, 61715, again, as you can see on the slide. And this code describes a non-invasive tissue ablation method within the skull without open surgery, and it may be used to treat essential tremors. And now I would like to turn the presentation over to Shelly.
Thank you, June, and welcome everyone. I'm going to start in the musculoskeletal section. Arthroplasty intercarpal or carpal metacarpal joints new code 25448 and revised codes 21630 radical resection of sternum and 25447 arthroplasty intercarpal and carpal joint. New code, the AMA, go back one code, June, thank you. The AMA Specialty Society Value Scale, RVS and RUC, and Relativity Assessment Work Group identified arthroplasty code 25447 as a service performed by the same physician on the same date of service as codes 25310, tendon transplantation or transfer, and code 26480, transfer or transplant of tendon, more than 75% of the time. In response to this analysis, code 25447 has been revised and code 25448 has been established. New code 25448 established to report joint arthroplasty procedures, transfer or transplant of the tendon, and the interposition of tendons when performed. Code 25447 was revised by transposing the term interposition after the semicolon and adding the parenthetical phrase, arthroplasty intercarpal or carpometacarpal joints, semicolon, interposition, example, tendon, and code 25448 interposition is not separately reported. Next, we're going to move to the integumentary section. And on this one, we're going to talk about skin cell suspension. Work involved was not accurately described in existing autograft tissue cultured autograft codes 15040 through 15261, or skin substitute graft codes 15271 through 15278. So the establishment of 8 Category 1 codes, 150 through 5011 through 15018 for skin harvesting, autograft preparation, and application of the skin cell suspension autograft, which are listed on the slide. Harvest, which is 15011 through 15012, epidermal and dermal skin. Preparation, which is 15013 through 15014, and then application. What does skin replacement surgery consist of per AMA CPT manual? The surgical preparation and topical placement of an autograft, including tissue cultured autograft and skin cell suspension autograft or skin substitute graft. This graft is anchored using the individual's choice of fixation, such as surgical glue, sutures, and staples, is included within this code. I have pulled some additional information out for your reference. For surgical preparation of the recipient site prior to application of the SCSA, see 15002 through 15005. Placement of a separate additional autograft, split or full thickness prior to application of the SCSA is separately reportable with 15040 through 15261. Repair of donor site requiring skin graft or local flaps is considered a separate procedure. Do not report debridement 97602 unless there is documentation of gross contamination that requires prolonged cleansing when applicable amounts of devitalized or contaminated tissue are removed, or when debridement is carried out separately without immediate primary closure. Next section is urology, gynecology. I'm going to starting with the urinary system procedures listed here. First procedure, MRI monitored transurethral ultrasound ablation of prostate. One of the major callouts to take note of is that code 55881 specifies transurethral and using thermal ultrasound. This differs from code 55880, which specifies high-intensity focused ultrasound, which is high intensity and is transrectal approach. Next slide. In addition, code 51721, 55881, and 55882 are used to report transurethral ultrasound ablation of the prostate for the treatment of prostate cancer. MRI is proven established imaging modality for evaluating and monitoring of the transurethral ultrasound prostate tissue ablation represented by these codes. Code 55882 combines the placement of the device and the treatment to match the work performed by the same physician. Exclusionary parenthetical notes have been added, precluding the reporting of these codes 51701, 702, 55881, 55882, 72195, 72196, 72197, 77022 in conjunction with code 51721 is reported for separate provisions of each service by a different physician. And code 55882 is reported for provisions by both services by the same physician. A parenthetical instruction following code 51721 directs users to code 55882 when both procedures are done by the same physician. The next procedure to reference is bladder, neck, and prostate, new codes 53865 and 53866. Separate codes have been established to describe the insertion of a temporary device to remodel the bladder, neck, and prostate, and the removal of a temporary device. New codes 53865 and 53866 reflect the new technology and the evolution of services currently rendered with cystourethoscopy for temporary insertion and catheterization removal. These codes are typically reported for the treatment of symptoms due to urinary outflow obstruction secondary to benign prostatic hyperplasia. Instructional parenthetical notes have been added to direct users to other procedures for reporting permanent urethral stent 52282 and cystourethoscopy with the removal of temporary device 52310. Excuse me. The next new procedure is histotripsy of kidney, new code 0888T. There was an early release date, December 2023, with effective date of July 1, 2024 for reporting category 3 code 008T. This new technique utilizes a non-invasive procedure at a subcellular level to destroy cancer tissue in the kidney. This is a non-invasive ablation technique with focused ultrasound waves that destroys targeted tissue. This code is now reflected in the 2025 CPT book. The next new procedure that I will be referencing is the cystourethoscopy renal nerve denervation, new code 0935T. Code 0935T was included in the early release Category 3 codes on July 1, 2024, with an effective date of January 1, 2025. Before July 2024, there was no specific code available to report treatment of uncontrolled hypertension by renal nerve denervation. Therefore, new code 0935 has been established to capture this new endoscopic transureteral approach to renal nerve denervation. Uses radiofrequency ablation to destroy nerve endings. The existing codes 52000 and 52005, 52007 use catheter-based renal denervation administration through the renal artery, which is a transarterial approach, which differs from the new code, which describes a transureteral approach. On July 1, 2024, code 0941T through 0943T were released from AMA with an effective date of January 1, 2025. New codes 0941T through 0943T have been established to report cystourethoscopy procedures. These techniques is clinically different than the existing techniques used with endoscopy. The code additions reflect new procedures that are not currently represented by a specific code and performed via flexible cystourethoscopy. These procedures are performed 3 different ways to report the evolution of prostatic urethral scaphoid services. With the establishment of these codes, it would be inappropriate to report an unlisted code for these services. This procedure relieves urinary symptoms and is minimally invasive procedure. The next procedure that I am sharing is the intraoperative fluorescent imaging margin assessment breast, new add-on code 0945T. Category 3 add-on code 0945T to report intraoperative assessment for abnormal tumor tissue following partial mastectomy. Used in conjunction with code 19301, mastectomy partial, when computer-aided fluorescent imaging is used following partial mastectomy to detect residual cancerous tissue. Previously, no code existed to report this procedure. Intraoperative fluorescent imaging margin assessment breast. Optical imaging agent is injected prior to lumpectomy procedure. Handheld probe is inserted into lumpectomy cavity, ensuring it is in contact with the tissue. Scan is performed to determine the patient's baseline fluorescent intensity. Probe scans the area, and any region suspected to contain residual cancer is identified and resected. Code 0945 is only reported once per procedure. Code 0945T is not to be reported with 88172 cystopathy evaluation of fine needle aspirate, or 0546T radiofrequency spectroscopy real-time intraoperative margin assessment at the time of a partial mastectomy. Next, we're moving into the digestive system. Another area where quite a few new procedures have been added this year that are listed above. I'll be starting with intra-abdominal tumor or cyst, where they can be located. The peritoneal cavity, such as stomach, liver, spleen, small intestine, mesenteric, the membranes, connective tissue, or retroperitoneal, the kidneys, adrenal glands, or ureters. Open excision or destruction intra-abdominal, new codes 49186, 49190. These codes describe excision or destruction of intra-abdominal primary or secondary tumor or cyst via an open approach. Includes cytoreduction, debulking, or other methods of removal of tumor or cyst. These codes are reported when the resected or destroyed intra-abdominal tumor and cyst do not directly arise from a resected organ. If a tumor arises directly from an organ or soft tissue, only the organ or soft tissue resection or destruction procedure code from which the tumor arises is reported. Here is additional specific information from the guidelines provided within the CPT manual. Codes 49186 through 49190 are reported based on the sum of the maximum length of each tumor or cyst excised or destroyed. Measure only the tumor and cyst, not the tissue in which the tumor and cyst may be implanted. If only a portion of a tumor or cyst is excised or destroyed, measure only excised or destroyed portion. Tumor and cyst should be measured in situ before the excision or destruction and documentation in the operative report. Measurement includes only the tumor and cyst, not the margins. Knowing the difference between excision and destruction procedure codes, what is the appropriate code to report? For codes 49186 through 49190, the appropriate for open resection or of recurrent ovarian, endometrial, tubal, or primary peritoneal gynecological malignancies without lymphadenectomy. But in contrast, codes 58943 to 58960 to report for all other open resection of initial or recurrent ovarian, endometrial, tubal, or primary peritoneal gynecological malignancies. There are guidelines that I do recommend you read throughout the AMA 2025 CPT manual on all of these codes and the different uses for these procedures. Next, peritoneal ascites pump services, new codes 0870T through 0875 have been established to report the implantation, replacement, revision, removal, and programming of a peritoneal ascites pump. The pump is a fully implantable, wirelessly charged, automatically and continuously pump ascites from the abdominal cavity into the bladder, where the body eliminates the ascites naturally. The physician monitors. These are used for patients with refractory or recurrent ascites, and previously no code existed to report these procedures. In the next two slides, I have offered tables for these codes to make it easier for reference of what is being performed and included by code to assist you when selecting these codes starting January 1, 2025. This table includes the implantation, replacement of ascites pump, and replacement of indwelling bladder and peritoneal catheter procedure codes. Next slide, along with this table, that includes revision, removal of the ascites pump system, and programming of the ascites pump system. Next, moving on to the endoscopic drug-coated GI balloon, new code 0884T through 0886T. 3 category codes have been established to report upper esophagus and lower colonic endoscopic drug-coated balloon catheter procedures to treat strictures. Traditional first-line treatment for strictures has been dilation with non-DCB catheters, high degree of stricture recurrence related to tissue regrowth and scarring. Previously, no code existed to report these procedures. 2-step procedure at the same encounter. Initial pre-dilation with a non-drug-coated balloon catheter, immediately followed by a drug-coated balloon catheter, which acts as a drug delivery system into the scar tissue when inflated. Fluoroscopic guidance is not separately reported. For multiple colonic strictures dilated during the same procedures, report modifier 59 with 0885T, 0886T for each additional stricture dilated. There are multiple exclusionary parenthetical notes that have been added and revised throughout the digestive system subsection to clarify the endoscopic drug-coated balloon catheter procedures should not be reported in conjunction with existing endoscopic procedures for the esophagus and colon rectum. Next, gastric electrophysiology mapping, new code 0868T. Category 3 code 0868T has been established to report high-resolution gastric electrophysiology mapping with simultaneously patient symptom profiling. Useful for identifying conditions such as chronic nausea and vomiting syndrome, gastroparesis, and functional dyspnea. Previously, no code existed to report this procedure. The procedure consists of the patient fasts for 6 hours or more. Anatomical measurements are taken. Baseline fasting recording is performed. Patient eats a standardized meal in greater than 10 minutes while data is continuously obtained. For a 4-hour postprandial period, patient logs symptoms every 15 minutes for a duration of test. While high-resolution gastric electrophysiology data is being collected, then the data is reviewed by a physician who interprets the results and generates a report. Next procedure is normothermic liver perfusion services, new code 0894 through T through 0896T. 3 category 3 codes have been established to report normothermic liver perfusion services for patients with liver disease or failure. Due to donor organ shortage, options to increase the availability of donor allografts includes preserving organ functionality using a normothermic machine perfusion device. Previously reported with code 47399, unlisted procedure liver. Normothermic liver perfusion services 0894T includes any effort necessary to prepare the liver for connection to the normothermic perfusion device, includes decannulation. Note, liver allograft preparation is distinct from the standard backbench work. 0895T, first 4 hours of monitoring time, physiological and laboratory assessment is included. 0896T, perfusion monitoring time varies considerably between donor allografts. Moving on to ophthalmology. There are a few new procedures in this area as well, and they are listed on this page. We will first be starting with the photobiomodulation therapy, new code 0936T. Code 0936T established to report photobiomodulation therapy of the retina, patients with dry eye, age-related macular degeneration, and vision loss. Parenthetical note provides instructions regarding how to report code when it is a bilateral procedure. The picture on this slide represents the procedure of a patient having the procedure performed. The patient sits in front of a light delivery system and the area is treated with the photobiomodulation for 4 to 5 minutes. Next is iris procedures, 668880, 6682, and 6683. Code 6680 and 6682 both are unchanged, but we have a new code 66683 that was added to report the implantation of an iris prosthesis, including suture fixation and repair or removal of the iris when performed. This code replaces Category 3 code 0616T, 0617T, and 0618T. Insertion of an iris prosthesis is performed for patients with conditions such as aniridia, absence of an iris, or traumatic injury to the iris. The Specialty Society Relative Value System, RVS, updated committee RUC updates for 66680 and 66682. Here is pictures of the surgery of 66683. Reasons to repair an iris: loss of vision, glare, congenital and acquired, restoration, and the main purpose of the surgery. It's a complicated procedure with 3 instruments in the eye. So the RVUs have been changed so that 66683 is the higher of the RVU. Next procedure is optical coherence tomography, OCT. The addition of code 92137, new technique. Revisions of codes 92132 and 92134 with updated terminology, and revisions to the parenthetical notes. The changes are due to the AMA, RUC, and Relativity Assessment Workgroup screen that showed a substantial increase in the utilization of code 92134 volume growth due to guide medical treatment of age-related macular degeneration and diabetic retinopathy, especially macular edema, introduction of OCT retinal angiography. In addition to creation of code 92137 to report computerized ophthalmic diagnostic imaging of the retina, including OCT angiography, the other changes include removal of the term scanning from the codes 92132 through 92134 because it no longer used to describe these tests. The addition of updated example in parenthesis optical coherence tomography, OCT, in the descriptors, and the revision of parenthetical not following code 76513, deleting scanning and including code 92137. OCT retinal angiography is performed by the same technical performing OCT retinal imaging using an upgraded instrument. The physician provides additional interpretation about the vasculature and blood flow in the retina. Addition of code 92137 required corresponding changes in the diagnostic ultrasound subsection of the radiology section and the ophthalmoscopy section of the medicine section, including parenthetical notes directing users to codes for non-injection angiography and updating terminology. Here is a picture of 92137 would look like, which is more work than the 92134. Now is time for our second poll question. For the procedure ablation of prostate tissue transurethral using thermal ultrasound, including magnetic resonance imaging guidance, what would be the appropriate CPT code to assign? A, 55899, B, 55882, C, 55880, D, 55881. Jordan, please, would you launch the poll question?
Yes, it is launched. We'll give it a few seconds. Thanks, Shelly. All right. It looks like B again is winning.
The correct answer was D, as the procedure specified transurethral and thermal ultrasound, which are specific to the new code 55881. Continuing on with evaluation and management. Now, a brief overview of some updates on evaluation and management for 2025, specifically G codes. For calendar year 2025, CMS is finalizing their proposal to allow payment of the office or outpatient evaluation and management visits complexity add-on code HCPCS G2211, prolonged office or other outpatient evaluation and management services beyond the maximum required time of the primary procedure, which has been selected using total time on the date of the primary service. When the outpatient E&M base code, the CPT codes 99202 through 99205, 99211 through 99215 is reported by the same practitioner on the same day as an annual wellness visit, vaccine administration, or any Medicare Part B preventative service, including the initial preventive physical examination, IPPE, furnished in the office or outpatient setting. It is recommended that if you want additional guidance on how to utilize adding this code, you reference the frequently asked questions PDF document at the link provided on this slide by CMS that goes into more detail. Hospital inpatient or observation, i.e. evaluation and management add-on for infectious disease. This add-on code is designed to recognize the additional complexity involved in managing patients with suspected or confirmed infectious diseases during inpatient or observation stays, especially when requiring specialized infectious disease expertise. Physicians with specialized training in infectious disease can utilize this code GO545, services included disease transmission risk assessment, mitigation, public health investigation, analysis, testing, and complex antimicrobial therapy, counseling, and treatment. Advanced Primary Care Management, APCM services. The new APCM billing codes incorporate elements based on current CPT codes for chronic care monitoring, transitional care management, and principal care management, and will be divided into 3 levels based on the number of chronic conditions and whether the beneficiary is enrolled as a qualified Medicare beneficiary. All 3 of these HCPCS codes, G0556, G0557, and G0558, will apply to APCM services provided by clinical staff and directed by a physician or other qualified medical care professional, such as a nurse practitioner or physician assistant, who is responsible for all primary care and serves as the continuing focal point for all needed healthcare services. Unlike CCM and PCM, the proposed APCM does not include a time threshold. Advanced Primary Care Management Services continued. 3 levels of coding based on an individual's number of chronic conditions and statuses as a qualified Medicare beneficiary, reflecting the patient's medical and social complexity. Level 1, which is GO556, is for all patients with 1 or fewer chronic conditions. Level 2 is G0557, is for 2 or more chronic conditions. And level 3 is G0558, is for 2 or more chronic conditions and QBM statuses. HCPCS code G0559 is a new add-on code created to report postoperative care services provided by a practitioner other than the one who performed the surgical procedure. The purpose: the code reflects the time and resources involved in postoperative follow-up visits. When to use: the code can be used for new or established patients, but can only be billed once during the 90-day global period. How to use: the code can be appended to an office E&M service. The code does not require a formal transfer of care agreement between the practitioner who performed the surgical procedure and the practitioner who will perform the follow-up visits. After consideration and public comment, see slide bullet 2. Originally, CMS proposed that the code may only be billed by a practitioner of a different specialty. However, after consideration of public comments they recognize that in some clinical scenarios, it is possible that a postoperative care would be furnished only by a particular specialty. So they are accepting that per CMS. Moving into our last part of the updates is on telemedicine services. Telehealth services were being performed prior to the COVID-19 public health emergency. Medicare had strict geographical limitations, and Appendix P existed. The coverage, coding, and payment policies for telemedicine prior to the public health emergency varied widely by payer, and in some cases was affected by state statute and regulation. Rapid expansion of services was required to address healthcare needs in many settings during the public health emergency, and practitioners and payers responded positively. The rapid response resulted in solutions that varied by payer and changed over time, which codes, modifiers, and sites of service. Time for AMA action. Key decisions and rationale. The AMA decided to create codes with clear descriptions of service. Create audio, video, and audio only. They are different in resources, both essential for care, potential for some payers will only recognize the audio video. New and established, there's potential resource differences. Some payers may only recognize the established patients given the CPT history with telephone codes, and then the use of medical decision-making and time. These are evaluation and management codes. These services are evaluation and management services like office and outpatient visits, except they do require communication-based technology. Telephone services, codes 99441 through 99443 have been deleted. You will now report telemedicine new codes 98008 through 98016. I have provided a table for easy reference to visually see the differences between the 2024 telephone codes and the new 2025 audio-only codes. This is highlighted in the 2025 AMA CPT book as well, and I do encourage everyone to reference these as it does reference the G code usage as well. The same categories and structure, these codes, telemedicine service code structure, they are the same as office and other outpatient codes, so 99202 through 99205 and 99211 through 99215 new patient. They use straightforward medical decision making, and 15 minutes of time must be met for 98000, just like for 99202, for example. So here are the new telemedicine codes for you to reference. Synchronous time, real-time interactive encounters between physician or other qualified healthcare professionals and the patient utilizing either combined audio or audio only for telemedicine service guidelines, unless specifically stated in code descriptive level selection for telemedicine services is based on either the level of the medical decision making or the total time of the evaluation and management services performed on that date of encounter. Telemedicine services are used in lieu of the person in service, person services. Telemedicine services are not to be used to report routine telecommunications related to a previous encounter, such as the to communicate a laboratory result. They may be used for follow-up of a previous encounter when a follow-up evaluation management service is required in the same manner as in-person evaluation and management services would be used. Except for 98016, these services do not require specific time from the last in-person or telemedicine visit and may be initiated by a physician or qualified health professional as well as by a patient or family caregiver. When performed on the same date as another E&M service, the elements of time of these services are summed and reported in aggregate, ensuring that any overlapping time is only counted once. Please reference your 2025 AMA CPT manual for the full list of code descriptions and guidelines. And last, the related revisions. related revisions throughout the 2025 AMA CPT manual due to deletion of CPT codes 99441 through 99443 and the addition of the new codes 98008 through 98016. Please make sure to look for all places that these codes have adds, such as codes added to parentheticals, prolonged services, care plan oversight services, interprofessional telephone, internet, electronic health record consultations, care management services, complex chronic care management services, principal care management services, anesthesia guideline services, medicine section, pulmonary ventilator management, E&M guideline overview. The telemedicine symbol is a star removed from office or other outpatient codes 99201 through 99205 and 99202 through 99215. Codes added throughout the book to be used in conjunction within the parentheticals. Appendix R is changes within the digital medicine services and taxonomy, and deletion of HCPCS code G2012 replaced with new code 98016. The AMA is staying active with CMS and these new codes and new technology, and with the continuation of codes covering advanced primary care management and SCOH code coverage. Deletion of G20012, the explanation of that. G2012 is a communication technology-based service for a brief virtual check-in by a qualified healthcare professional. The new code 98016 will be used to cover short virtual check-ins. This presenter was excited hearing from the collaboration of both entities at the symposium and their eagerness to continue to work together to bridge many of these healthcare topics coming our way. Thank you for your time. I'm sorry that I went over. There was just a lot of information this year. And I'll pass it back over to you, Jordan, to see if there is any questions that we could answer quickly.
Thanks so much, Shelly, and June. I know that was a ton of information. So there is one question that came in. Can you explain how it's calculated and what should be the verbiage used by providers for telehealth new CPT codes?
You mean how is the telehealth codes calculated?
Yes.
So it can be calculated by time and medical decision making.
Great.
And there is a lot of directive in the guidelines in the CPT book for that.
Great. And then June, can you revisit the influenza virus vaccines again? The revisions and deletions. I think it's on slide 24. I know there were.
Yeah, as far as the influenza vaccines, that they were, let me go back quickly to that slide. Hang on for that. Is slide 24. Just to verify that question. And yes, that there were two new codes that were available, that are available for, there we go, for use, and those are recommended, the different dosages based upon ages. As you can see, the first one for the 30 mcg with code 90637, that is recommended for individuals ages 18 through 64, while a higher dose, the 60 mcg, is recommended for ages 65 years and older. And so there were also other changes for obsolete products that you can see, as well as that title revision. And so that is part of the work and the proposals from the ICC committee for those.
Great. All right, so I think we're going to go ahead and wrap up. Just a reminder, the recording, the copy of the slide deck, and a certificate of attendance is all going to be made available to those who attended today. And also registered. Thank you so much for your time. Thank you, June and Shelly, again. I hope you found everything useful. And if you have any questions regarding like technical support or even content questions, please contact our customer support at customersupport@imohealth.com. If you have any questions regarding IMO Health Solutions, email our sales team at sales@imohealth.com. Thank you so much for attending, and I hope you all have a lovely holiday season. Thanks. Bye.